So for those of you who don't know me, my name is Limonte, and I'll be talking about SGLT2 inhibitors, real-world use, and special populations. And this is meant to be a very broad overview of these topics. So as implied by the title, my talk is divided into two parts. First, I'll discuss real-world use of SGLT2 inhibitors, specifically aiming to answer the questions, how has SGLT2 inhibitor use entered routine practice? And what do benefits and risks of these agents look like in the real world? And for these questions, I'll just be focusing on kidney-related outcomes. Then I'll discuss SGLT2 inhibitor use in special populations and answer the questions, who else from the folks who are in the guidelines may experience kidney and cardiovascular benefits with SGLT2 inhibitors, and are there other potential indications for these agents? By this point, most of you are familiar with the landmark SGLT2 inhibitor trials. Most of these focused primarily on cardiovascular outcomes. These are indicated by the red boxes here. And early on, most of these trials were conducted in people with type 2 diabetes, indicated by the yellow border. So most of these cardiovascular outcome trials found SGLT2 inhibitors to slow kidney function decline and thus pave the way for our favorite primary kidney outcome trials shown in blue: Credence, ADPKD, and most recently EMPA-KIDNEY. Together, these trials established the basis for present-day use of SGLT2 inhibitors. And so what were their big takeaways? Well, from these studies, we know SGLT2 inhibitors have kidney and cardiovascular benefits across all GFR categories, or all studied eGFR categories. This is regardless of diabetes status. This was shown most recently in EMPA-KIDNEY, which recruited adults with and without diabetes, and with an eGFR greater than or equal to 20. In a pre-specified subgroup analysis, participants across all eGFR strata experienced benefit in cardiovascular and kidney outcomes. Furthermore, absolute benefit is actually greater in lower eGFR groups. This table is from a combined analysis of EMPA-REG, Canvas, Credence, and DECLARE, and shows that with lower eGFR, the number needed to treat per 5 years to prevent one kidney outcome gets smaller. And also among those with eGFR 15 to 30, a meta-analysis of 6 placebo-controlled randomized trials, including over 2,000 participants, both with and without diabetes, found that SGLT2 inhibitors reduce the risk of worsening kidney function or kidney failure by 23%, and slowed eGFR decline in this very high-risk group by 1.2 milliliters per minute per year. And so even in this lower eGFR range, SGLT2 inhibitors have demonstrated promising or strong kidney benefits. And how do SGLT2 inhibitors fare across albuminuria categories? Well, there's clear benefit of SGLT2 inhibitors across all albuminuria categories in type 2 diabetes. And we know this from the cardiovascular outcome trials, Canvas, DECLARE, and EMPA-REG outcome. There's also apparent benefit in kidney outcomes across albuminuria categories in people without diabetes, but with systolic heart failure. EMPEROR reduced is a good example of this. Over half of the patients in the study had a urine albumin creatinine ratio of less than 30, and they experienced less eGFR decline with SGLT2 inhibitors compared to placebo. There's also a trend towards benefit in kidney disease progression in DAPA-HF, which also didn't have a lot of albuminuria. However, EMPEROR preserved, which enrolled patients with heart failure and preserved ejection fraction, also didn't have a lot of diabetes or albuminuria to start, and didn't find much of a kidney benefit with SGLT2 inhibitors. And as I know has been a big topic of conversation with EMPA-KIDNEY, benefit was unclear in the low albuminuria subgroup there as well. So overall, I'd say more evidence is needed for the specific population, CKD without albuminuria, without systolic heart failure, but I am hopeful for benefit. Benefits in SGLT2 inhibitors, kidney and cardiovascular outcomes have resulted in incorporation of these drugs into nephrology, diabetes, and cardiology practice guidelines. These are summarized here. So last year, KDIGO named SGLT2 inhibitors first-line therapy for type 2 diabetes and CKD with an eGFR threshold of 20 for initiation. Just this year, the American Diabetes Association released guidelines saying that SGLT2 inhibitor use should be determined by the presence of kidney and cardiovascular comorbidities and risk factors instead of being determined by A1C alone. And so this was a big shift in thinking of diabetes care as not wholly focused on bringing down A1C or glucose to target levels, but rather treating risk factors associated with this disease. And the American Heart Association named SGLT2 inhibitors a cornerstone of guideline-directed medical therapy for not only symptomatic chronic heart failure with reduced ejection fraction, regardless of type 2 diabetes status, but also in people with mildly reduced and preserved ejection fraction. And actually the recommendations in the preserved ejection fraction group are higher than those for other drugs that we've been using for decades, ACE inhibitors, et cetera. And lastly, the American College of Cardiology recommends SGLT2 inhibitors in people with type 2 diabetes and atherosclerotic disease or high risk of this. How's the FDA telling us we should use SGLT2 inhibitors? Well, there are 4 agents which currently have FDA approval: empagliflozin, dapagliflozin, canagliflozin, and ertugliflozin. And these all have glycemic control as indications for use. And these 3 have reducing heart failure complications and cardiovascular complications as indications. Only dapagliflozin and canagliflozin have strict DKD indications, and out of all of these, only dapagliflozin has a CKD indication. EGFRs to initiate differ across these drugs, but are higher than what's been found to be safe in clinical trials. So FDA is behind here. And labels for all of these drugs explicitly recommend avoiding in type 1 diabetes, but only list hypersensitivity reactions and dialysis as strict contraindications. Notably absent from this table is sotagliflozin, our SGLT1 and 2 inhibitor, which is still awaiting FDA approval. In line with randomized controlled trials, studies designed to assess kidney outcomes of SGLT2 inhibitors in real-world settings have consistently demonstrated benefit. CVD REAL 3 was a multinational observational study that compared kidney outcomes in people with type 2 diabetes initiated on SGLT2 inhibitors versus other glucose-lowering drugs. This study was comprised of about 65,000 people from all over the world, and most had normal kidney function at baseline with a mean eGFR of 90. The figure on the right shows eGFR trend over time. Over 24 months, SGLT2 inhibitors, the red line here, resulted in reduced eGFR decline by about 1.5 milliliters per minute per year. Also, half as many people on SGLT2 inhibitors experienced the composite kidney outcome. An observational study in Singapore focused more on people with type 2 diabetes and CKD compared to this other study, which had people with largely normal kidney function. So the study in Singapore compared SGLT2 inhibitors versus standard therapy, included about 4,000 people. 28% had an eGFR of 15 to 44. Over about 6 years of follow-up, SGLT2 inhibitors were associated with decreased likelihood of CKD progression. And this specific figure is showing how event-free survival was greater with the drug, specifically in this lower eGFR range. With respect to adverse outcomes, real-world effects have also mirrored clinical trial data. And here I'll show you adverse events of SGLT2 inhibitors from a systematic review of 37 population-based observational studies, and from all around the world, comprising 1.3 million adults followed for over 900,000 person years. Included studies compared SGLT2 inhibitors to other glucose-lowering therapies or usual care. And these studies use data from insurance or population registries. So there was clear risk of genital mycotic infections with SGLT2 inhibitors, and all of the studies included in this review, as 3 studies, showed about double or more risk with SGLT2 inhibitors. There was also a potential risk signal for DKA. Only 2 out of 5 studies showed significantly increased risk with SGLT2 inhibitors. The others trended towards significance. Overall, the event rates were pretty low, which probably accounts for how this was null in some studies. And there was also a potential risk signal for amputation. So 2 out of the 8 studies showed significantly increased risk of amputation with SGLT2 inhibitors, and the others trended largely towards significance. And lastly, there was no risk found of AKI, fracture, and UTI. And in fact, it seemed as though SGLT2 inhibitors were actually protective against AKI. Also worth noting, SGLT2 inhibitors increase proximal tubular phosphate reabsorption in a sodium-dependent manner, and this triggers a cascade of changes of mineral metabolism markers. This figure is from a crossover study of healthy participants given canagliflozin or placebo for 5 days. With canagliflozin, there was a rise in phosphate, which is believed to have triggered an increase in plasma FGF23, resulting in decreased 1,25 dihydroxyvitamin D, which in turn decreased intestinal calcium absorption. In response to all of these changes, PTH rose. And while by the end of the study period, phosphate and 1,25 dihydroxyvitamin D were back to baseline, it seems like it took an increase in PTH to get there. Again, this study was done in healthy participants. There is some evidence to suggest that the rise in phosphate and PTH may be more pronounced and sustained in people with comorbidities like diabetes or CKD. This is a visual abstract from a similar crossover study using dapagliflozin, though now in participants with type 2 diabetes and albuminuria followed for longer, 6 weeks. By the end of the 6-week period, rises in phosphate, FGF23, and PTH were significant and sustained, albeit small. And why does this matter? Well, higher concentrations of these markers have been associated with adverse outcomes and increased mortality, though not without some controversy. And overall, the long-term risks, if any, accompanying mineral metabolism changes from these drugs are unclear and will need more study. Now, moving on to our discussion of special populations. I'm going to talk about SGLT2 inhibitors for kidney and cardiovascular benefits in people with type 1 diabetes, kidney transplant, ADPKD, dialysis, and then about kidney stones and SIDH as potential novel indications for SGLT2 inhibitors. There have been several moderately sized randomized placebo-controlled trials of SGLT2 inhibitors in people with type 1 diabetes. These are the EASE, DEPICT, and In Tandem study series. And these trials have lasted about 6 months to a year each and have largely focused on safety and glycemic effects. Overall, studies showed that SGLT2 inhibitors resulted in reduction of hemoglobin A1C and more time in which blood glucose was in range. There were also significant blood pressure lowering and weight loss effects. Importantly, SGLT2 inhibitors did not increase risk of hypoglycemia and actually decreased symptomatic hypoglycemic events, especially when occurring at night. Secondary analysis of these RCTs have been performed looking at kidney outcomes, and results have been generally promising. Data from pooled in tandem 1 and 2 trials is shown here. Sotagliflozin resulted in an eGFR drop on initiation, suggesting the renoprotective hemodynamic effects are at play. And while this population didn't have a lot of kidney disease, among people with albuminuria greater than 30, sotagliflozin did significantly reduce urine albumin over the course of a year. Kidney benefits have also been apparent in real-world settings. This is data from a European cohort of about 200 adults with type 1 diabetes initiated on an SGLT2 inhibitor. After 12 months, SGLT2 inhibitors were associated with a 5% increase in eGFR in people with an eGFR less than 90, and with a 50% reduction in albuminuria in people with albuminuria greater than 15. Though, admittedly, the sample size here was very small. There is a higher risk of decay with SGLT2 inhibitors. And this analysis of 18 randomized trials concluded that the risk of DKA with SGLT2 inhibitors was almost 3 times of that with placebo or other glucose-lowering agents. This amounts to a risk of DKA with SGLT2 inhibitors of 3 to 4%, compared to about 1% in placebo groups. The risk of DKA increased with higher drug doses. And this study also identified specific factors associated with DKA: BMI greater than 27, greater insulin resistance, and volume depletion. I think this is especially noteworthy because the better we can identify risks of complication, the more safely we can ultimately prescribe these agents, and the better we can counsel our patients. Moving on to kidney transplant recipients. In this population, there have been a few small RCTs which have focused on glycemic control and safety. One of the larger studies I found included 44 kidney transplant recipients with diabetes who were randomized to empagliflozin versus placebo and followed for 24 weeks. SGLT2 inhibitors resulted in significant reductions in hemoglobin A1C and weight, and the change in A1C was dependent on baseline eGFR, as we've seen in the general population. And there were no significant differences in adverse events or on immunosuppressant drug levels, indicating that these drugs are not affecting our immunosuppression. Beneficial kidney outcomes have also been described in observational studies. And this study compared 200 people who had kidney transplants and were on SGLT2 inhibitors with 1,800 participants who were receiving usual care. And those on SGLT2 inhibitors were 55% less likely to experience the primary composite outcome of all-cause mortality, death-censored graft failure, and creatinine doubling. So all in all, SGLT2 inhibitors seem promising for kidney transplant recipients. There have been some reports of UTIs as adverse outcomes, which we haven't seen in the general population. And this honestly seems plausible to me given these patients' distinct anatomy, but overall more data is needed. Now on to ADPKD. So the pathogenesis of ADPKD, cyst formation and expansion, includes altered glucose metabolism and intracellular signaling pathways, notably the AMPK and mTOR pathways, as well as impaired autophagy and mitochondrial dysfunction. These are all processes which may be ameliorated by SGLT2 inhibition by those glomerular tubular feedback mechanisms. So, however, SGLT2 inhibition by inducing volume loss has been demonstrated to increase release of vasopressin, which can actually increase cyst growth. Data from animal studies has been inconsistent. In this study conducted in PCK rats, dapagliflozin resulted in increased cyst volume, kidney weight, and albuminuria. However, in another study using a different rat model, fluorazin, a dual SGLT1 and 2 inhibitor, actually decreased cyst epithelial proliferation. These rat models don't exactly pathogenically replicate human ADPKD. This PCK rat model is actually modeled for autosomal recessive PKD. And so really more data, especially in human cohorts, is needed. And certainly our very own Bino Friedman and his lab actually demonstrated that blocking glucose uptake using fluoratin, another SGLT1 and 2 inhibitor, reduced cyst growth in human kidney organoid model of PKD. So more data in human cohorts is needed, but for now, SGLT2 inhibitors are discouraged in ADPKD. There are no major published studies in human hemodialysis or peritoneal dialysis cohorts, but plenty of studies are ongoing. A keyword search of ESRD and SGLT2 inhibitor in clinicaltrials.gov yields over 70 results. I've pasted the names of some trials here to get everyone excited. Many of these have a mechanistic bent or focus on safety and tolerability. For example, study looks at how empagliflozin affects endogenous glucose production, and this one focuses on pharmacokinetics and dialyzability. There are some unique considerations for peritoneal dialysis patients with respect to SGLT2 inhibitors. So SGLT2 and other glucose transporters are actually expressed in the human peritoneum. And there are some studies that are maybe showing that expression may be enhanced in encapsulating peritoneal fibrosis. That's here compared to controls. And in mice exposed to high glucose peritoneal dialysate, administration of SGLT2 inhibitors reduced peritoneal thickening and fibrosis. It's comparing these two bars here. And there's also some evidence suggesting that treatment with fluorescein, the dual SGLT1 and 2 inhibitor, reduces peritoneal glucose diffusion capacity and may ultimately end up helping with ultrafiltration because you're absorbing less glucose. So again, a theme, more studies are needed. Now moving on to other potential indications of SGLT2 inhibitors. So SGLT2 inhibitors may help manage kidney stones. These are results from a pooled analysis of 20 trials in which adults with type 2 diabetes were randomized to empagliflozin or placebo. This includes the EMPA-REG outcome trial. At baseline, less than 1% of these participants had a history of kidney stones. And most of these participants, about 80%, had an eGFR greater than 60. Over 1.5 years of follow-up, urolithiasis incidence rates were higher with placebo than with SGLT2 inhibitors. We saw one event per 100 patient years in the placebo group compared to 0.6 events for 100 patient years in the SGLT2 inhibitor group. And overall, SGLT2 inhibitors were associated with 40% reduced risk of urinary tract lithiasis. The primary proposed mechanism here is osmotic diuresis that's increasing urinary flow rate. There's also some evidence that SGLT2 inhibitors increase urinary citrate and bicarbonate excretion, which protects against some stone types. However, SGLT2 inhibitors also increase urinary uric acid excretion, which may not be favorable for those who make uric acid stones. There is an ongoing randomized placebo-controlled crossover trial being conducted of empagliflozin in adults with at least one prior kidney stone event, calcium or uric acid containing, and without diabetes or CKD. Participants will receive empagliflozin for 2 weeks, undergo a washout period, and then switch to placebo or vice versa. And the primary outcome of this trial is urinary supersaturation of calcium oxalate, calcium phosphate, and uric acid, with secondary outcomes of including electrolyte measurements and urine volume. And it looks like this study was recently completed, so hopefully we'll have some data over the next year or two. And lastly, SGLT2 inhibitors may help manage SIADH. The underlying mechanism here is that glucosuria induced by SGLT2 inhibitors causes an osmotic diuresis that results in free water excretion. 2 randomized controlled trials have demonstrated improvements in serum sodium with SGLT2 inhibitors compared to placebo in both inpatient and outpatient settings. So the first study was conducted in inpatients with SIADH and a serum sodium of about 125. Patients were randomized to empagliflozin or placebo, and all were placed on a 1 liter fluid restriction. Looking at this graph, you can see serum sodium rises in both groups, maybe a little bit more, maybe a little bit faster with empagliflozin. Overall, they described that serum sodium rose by 10 with the empagliflozin compared to 7 in the placebo group. The second study was conducted in outpatients with chronic SIADH and a serum sodium of 130. This was a crossover trial, so patients received either empagliflozin or placebo for 4 weeks, had a 2-week washout period, and were given the opposite intervention. And all patients were placed on a 1.5 liter fluid restriction. Sodium improved to about 134 within 1 week of starting SGLT2 inhibitors and stayed steady, whereas in the placebo group, there was no effect. SGLT2 inhibitors also resulted in a small but significant improvement in the MoCA score, suggesting that this improvement in serum sodium had neurocognitive benefits in neurocognitive function. So in conclusion, data from randomized controlled trials have led to SGLT2 inhibitors becoming important agents for the treatment of type 2 diabetes and CKD, heart failure, and atherosclerotic cardiovascular disease. Real-world studies consistently demonstrate benefits of SGLT2 inhibitors and are important for better defining risks. Our understanding of SGLT2 inhibitor effects in type 1 diabetes, kidney transplant, ADPKD, and dialysis populations is growing. And SGLT2 inhibitors may play a role in the management of kidney stones and SIDH. And I'd like to thank my UW mentoring team, especially Ian DeBoer, for teaching me everything I know about diabetic kidney disease and reviewing these slides. So I'm happy to take any questions.
Excellent. Thank you, Dr. Limonte. Questions for Christine?
I have a question, Christine. That was a wonderful talk. I learned a lot. I was just curious your thoughts on future clinical research directions for CKD. Do you feel like we have enough clinical data to say, okay, we don't need to test this anymore? And maybe, what are your thoughts on specifically CKD?
Yeah, so I mean, I think we still need more data for the CKD, non-diabetes, no albuminuria group, because really that's just based on pooled data from cardiovascular outcome trials, most of which include people with systolic heart failure. And I think a lot of where this research is going to go, as well as in defining populations that are most likely to benefit. So identifying disease subgroups that would benefit from SGLT2 inhibitors started at a specific point in time. Part of this includes understanding the mechanisms by which SGLT2 inhibitors cause benefit. We talk a lot about tubular glomerular feedback, but we're increasingly understanding that there are metabolic effects of SGLT2 inhibitors, benefits on mitochondrial function, et cetera. So I think as we better understand those mechanisms and get more clinical data in specific populations, we can cater therapies to specific populations. And that's important, I think, not only for, from a precision medicine standpoint, but from like a cost standpoint. Yeah, I think that's.
Christine, this is Leah. In the EMPA kidney paper, there seemed to be a signal that the people who were on RAS inhibition benefited sort of the most from SGLT2 inhibitor addition. And I'm just wondering what you think in terms of whether there's synergy there, because a lot of times when people can't tolerate a RAS inhibitor, we just say, well, just put them on an SGLT2 inhibitor. But the fact of the matter is that most people were on these, already in these studies. And those people seem, so if you could comment on that. So.
Yeah, thanks, Leah. That's a great question. And that was the point I wanted to make for Laura too, that another direction research is going to go is understanding how can we combine these therapies with RAS inhibition, GLP-1 receptor agonists, mineralocorticoid receptor antagonists. Leah, I'll admit I didn't dive deeply into that literature for the purposes of this talk. So
no worries.
I'm not. Well, I do know that there is an additive benefit with RAS inhibition, but I don't know if it's like a multiplicative, or I know there's additional benefit, but I don't know if it's like additive or multiplicative. I don't know the specifics of that interaction.
Well, thank you, Dr. Limonte. Excellent talk. I suspect I wasn't the only one to take screenshots of your nice summary slides. We will move on.